Great,
Sure.
thank you. And we're recording this, so I know we'll have this available to many others who were unable to join us today. Um, I want to welcome you all to the Collaborative and Health Equity, kicking off one of our global health seminars. And we're excited for you to be with us today. I'm going to turn it over to Gurutse Parluenga, who will speak on behalf of our director, Dr. Anindita Deb, for Global Health, who couldn't be with us today, but we're going to just share just brief overview around our global health arm of the Collaborative and Health Equity. Gurutse?
Yes, thank you, Krista. So yes, I'm Guruchi Barlanga, Program Manager in the Collaborative in Health Equity. Good morning, good afternoon. This is what happens when you work in global health. You have to say all times of the day. On behalf of the whole team, on behalf of Dr. Anindita Dev, Director of Global Health, thank you for joining us today to welcome Dr. Sierra Washington to our Global Health Seminar series. Um, as some of you may know, the Global Health Core of the Collaborative seeks to advance global health equity through longitudinal collaborative partnerships and global bilateral exchange to improve health, healthcare service, research, and education through sustained impact. And I just want to remind those of you that are part of the faculty at UMass that we have regular global health faculty meetings. Our next faculty meeting will be next Friday. In these meetings, we share resources, funding opportunities, experiences. We celebrate together. And if you are not part of our mailing list, please reach out to us. We will be happy to add you. And speaking of celebration, we will be holding our global health, our first ever UMass Global Health Symposium on April 29th. That day, we are hoping to first, through our call for posters, we want to celebrate the global health work that is taking place at UMass, global health work done by faculty, students, learners of all kinds, staff, clinicians, and we will have posters. We will have Dr. Micaela Ubusu talking about advancing global child and adolescent health through education and collaboration. She has a lot of experience working in Liberia too. And we will also showcase our long-standing partnership between UMass and Baikaka University. And we will welcome, as part of that, Dr. Sumashekar, along with our UMass faculty, Dr. Fahey and Dr. Soni, to a panel to discuss this long-standing partnership. So please, even if you can only join us for part of this event, we would love if you can join us that day. And back to you, Dr. Krista.
Wonderful. So it is truly an honor for me as the Executive Director of the Collaborative and Health Equity to introduce Dr. Sierra Washington, who is a clinical associate professor in the Department of Obstetrics, Gynecology, and Reproductive Medicine, as well as the director of Stony Brook Center for Global Health Equity at the Renaissance School of Medicine at Stony Brook University. Dr. Washington has dedicated her career to the world's underserved populations. She is a graduate of Harvard Medical School and holds a Master's of Science in Public Health from the London School of Hygiene and Tropical Medicine. She completed residency in obstetrics and gynecology at the University of California, San Francisco, and is board certified as well as a fellow of the American College of Obstetricians and Gynecologists. Dr. Washington draws upon her extensive work across not only the United States, but Mozambique and multiple other countries in sub-Saharan Africa, including Zambia, Cameroon, Kenya, Rwanda, and Tanzania. Since July of 2020, she's been the Director of Global Health at Renaissance School of Medicine, Stony Brook, And in this role, she is leading innovative strategies to improve healthcare access in underserved communities with a particular focus on reproductive health. She provides on-the-ground direction in Mozambique, from identifying and cultivating key clinical areas of research and collaboration to developing administrative infrastructure that runs the program. On a personal note, I've known Dr. Washington for well over a decade, if not more. She's been a fearless and tireless champion of reproductive health and justice in both domestic and global contexts. A couple years ago, she invited me to speak at one of her global health symposiums, and during that event, I heard just a brief overview of the amazing work that she is leading in Mozambique, and it literally took my breath away. She truly has the gold standard of what we should be seeking to emulate. So we are truly in for a special treat today. So today she'll share with us her expertise in global health and reproductive care. Her remarks entitled Stony Brook Center for Global Health Equity, Advancing Healthcare in Mozambique. She will provide context-specific, actionable insights to support targeted efforts aimed at strengthening healthcare systems and advancing equity. So I'm so humbled to call Dr. Washington a dear colleague and friend, and we are also honored that she took the time out of her busy schedule to be with us today. So I will turn it over to you, Dr. Washington. Thank you so much. We welcome you.
So firstly, greetings and salutations from Mozambique. It's 3 in the afternoon, a balmy 80 degrees. And I just want to thank everybody for showing up at 9 a.m. I know that this is normally a noon seminar. So for those of you who made it, I appreciate you taking the time out of your other duties to come join us. I just, since we're in a small group, I just wonder if people could just turn on their video for 1 second or two so I can just see people's faces and get a show of hands, just so I know who I'm talking to. It's really hard when we're living on Zoom and from disparate parts of the planet. So if it is available to you, do turn on your video. And then we're just waiting for a few more people, and then you can turn off and go back into anonymity. So maybe Ope, Nisha, and Julia, if you're able to turn on your videos for just a few minutes. I firstly just wanted to understand how many physicians I'm speaking to, maybe just by a raising of the hand. How many physicians I'm speaking to, and how many social scientists I'm speaking to, or and how many students I'm speaking to. One student, maybe two, maybe Ope chimed in earlier saying she was a student. So I just want to thank all of you, social scientists, administrators. I believe Gorutze is an administrator, and the person who is collaborative in global health equity is also sounds like an administrator. So first, just thanks for taking the time and keeping the word equity in your title in these strange times that we exist. And I love seeing the diversity in age as well as gender and ethnicity and race here in this group. So let's get started. I'm just going to share my screen, and feel free to turn off your video now that I have an idea of who I'm speaking to. So I'm just going to ask you to, for the next hour, I always start my talk by thinking about how we can dream big together and reconsider our models for how we engage with the rest of the planet, especially from academia in the global north. So as Krista introduced, my name is Sierra Washington, and in terms of disclosures, I will say I do have a vested interest in the success of the program that I'm going to present today. And I will shamelessly ask you for money because we function on private donations and the goodwill of like-minded people. I just want to take a moment and honor the women that have died today from maternal mortality and causes directly related to pregnancy and childbirth. Every single day, we lose two 747 jets worth of women due to causes related to pregnancy and childbirth. That's quite a number, and I can only imagine the news cycle if two 747 jets full of white women from America went down with 100% fatality over the Atlantic Ocean. I can imagine the news cycle, but we don't hear about maternal mortality in the news. And I believe this is why. This is a map of the rates of maternal mortality displayed. Countries are displayed, their landmass is proportional to the rate of maternal mortality. So you can see in the United States where it's like very small, and Canada even smaller, Europe at almost non-existent, because maternal mortality is lower in these areas than in sub-Saharan Africa and the Indian subcontinent. And people always try to talk about maternal mortality and abortion care as two separate issues. But I just want to remind everybody that pregnancy starts and lasts for 9 weeks, and death from unsafe abortion is also a maternal mortality. And although unsafe abortion accounts for only anywhere between 8 and 13% of maternal mortality worldwide. In Africa, it's as high as 30% of maternal mortalities are from unsafe abortion. So I just encourage you to stand in your ethics and stand in your position when talking about maternal mortality. Don't forget to include death from unsafe abortion, especially as we enter in this very difficult time historically. We work in Mozambique, and in Mozambique, we have 10 times the maternal mortality than that of the United States. So in the United States, we lose about 27 per 100,000 women. And in African American women, I would be remiss if I didn't say it's almost double in the United States for Black women. And in Mozambique, though, we have 289 maternal mortalities per 100,000. And in the hospital that I work, we have an enriched population of high-risk women. And so actually our maternal mortality rate within our hospital is more like 350 per 100,000. So people always ask, you know, why are you working there? And I think it's really important that we don't ignore the historical context that the raping and pillaging of natural resource and human resource over generations in the continent of Africa have led to a whole continent that is systematically under-resourced. And so as we're in this time, as I reflect in this time where we're defunding USAID and we're stopping all foreign aid, I have actually always thought of foreign aid as reparations, because the only reason that the United States exists in the wealth that we live, and Europe exists in the wealth that we live, is that we spent generations pillaging Africa. And that's why I feel an ethical obligation that those of us from rich nations do have an obligation to give back. And just a moment about, you know, how I think of equity. You know, I think it's important that we just take a step back. I might be preaching to the choir. People might already have thought of the difference between equality and equity. But the way I think of it is that people who need more get more. That's what equity means to me. People who have greater needs need to have more effort, more money, more resource, so that they can have an equal and fair shot at liberation. So in a nutshell, I feel like a medical institution from one of the richest countries in the world, as somebody who's participating in that community, I feel that we have an ethical responsibility and actually a moral obligation to lead any international health collaboration by helping others to decrease morbidity and mortality, and that we should lead all of our endeavors with improving the quality of care and really squarely focus on that. And this differs than many academic collaborations that lead with research or lead with education. And so I think our ethos at the Stony Brook Center for Global Health Equity is everything begins with leading with improving the quality of care. But why, basically, what are the benefits of a global health collaboration? So I think there's obvious benefits in the realm of education when an institution from the global north, a medical school from the global north engages in a partnership with the global south. We can together collaboratively strengthen postgraduate education. We can help improve the quality of care by teaching new clinical skills. And in a well-selected collaboration, you could have national impact and create novel opportunities for learning. And when you bring skills, equipment, and innovation to the field, and people are stimulated, you can also decrease brain drain of top talent who might be looking to go elsewhere. If we look at African perspectives over the years on academic collaborations between academic medical centers and African medical centers, there's a number of studies that come out of the Indiana University, Moy University collaboration, which is one of the longest running academic partnerships that I'm aware of. And they've actually surveyed their residents in 2014 and again in 2020 that cited that having this type of collaboration increases their clinical skills, their confidence, and their exposure to different styles of professionalism, improved knowledge in pre and post testing. And many Kenyan residents who traveled to the United States as part of their residency in Kenya cited that their exchange to Indiana was the most important aspect of their training. And 93% of the participants in that program stayed in Kenya and worked there instead of leaving. In terms of the evidence across different areas of medicine, there was a survey done across GME looking at incoming interns at 3 institutions in 2009. And 2/3 of interns at that time reported they were likely to include global health in their career. And 77% of interns at that time reported interest in participating in a global health elective. And so as educators, the question is, how do we do that? How do we please the current generation in a responsible way without engaging in medical tourism? If we look now across different disciplines, in OBGYN, there was a CREOG survey, which is our resident survey, and they surveyed almost 5,000 residents. And 96% of residents rated that a global health experience was somewhat or very important in their education. Yet only 18% had arranged electives, and almost half of those electives that had been arranged were sort of self-arranged, and many used their vacation. And so there was a thought that residency programs basically need to create more access to more organized global health opportunities, and that centralization of these opportunities across a medical center would make most sense financially. What's interesting is Dr. Noor et al. Dr. Noor is from the Brigham and does work with refugees. And she did a cross-sectional survey of OBGYN graduates from 97 to 2015. And at that time, almost everybody who had completed a global health elective in their residency had then associated a career that had some global health aspect or was working on disparities. So I really feel like to train an OBGYN in 2025 to be to be a global citizen and world ready, to understand the spectrum of disease across the world, that actually it enriches the residents to have a global health elective. But then the question is, how do we do that in a responsible way? Without dwelling on it too much, similar literature exists in pediatrics, where as incoming interns said that 70% of them said they were likely or very likely to volunteer in lower middle income countries in their career. Surgery as well. has done a survey of residents, and 95% of the residents said they were interested in a global health elective, and half said they would finance it themselves if their residency couldn't support them. The same we see in family medicine, in anesthesia, in emergency medicine. And so across the board, we're raising a generation of doctors who want to be global citizens, who are engaged in the world and are asking for a global health experience as part of their training. And so coming at it from an institutional standpoint, like if you're the executive VP of an institution, why you kind of have to pitch, like, why should you engage in global health? Well, if you're the dean of a medical school, you can actually interest higher caliber trainees, rank and match higher caliber candidates if you have a robust global health program. You can promote careers that actually focus on health disparities. And it does help to retain top junior faculty. And I know I'm not allowed to use the words DEI if I worked for the federal government, but thanks God I don't. I do believe that because there's many first and second generation immigrants to the United States, that when you have a global health program, you can actually retain more diverse faculty who are interested in working in similar like communities from where their families came from. And so in terms of research, why would an institution care to be involved in global health? Well, actually, out of the top 10 medical schools ranked on the US News and World Report for top 10 for research, 10 out of 10 of them have robust global health programs. And so developing a collaborative research agenda can also benefit both partners in the global South and the global North. And I just want to take a moment to talk about two programs that I consider success stories, which is the IU Kenya program and the UCSF Global Program in Anesthesia and Surgery. So the IU Kenya program started in the mid-'80s, and they decided, you know what, we're just going to go in whole institution to whole institution. And they put boots on the ground in the mid-'80s, really with a focus on medical education, but they realized that they couldn't just focus on medical education because they were in the middle of a scourge of a global pandemic of HIV. So they got into HIV care and treatment, HIV prevention, and then they realized they needed a field director in internal medicine. They hired a full-time internal medicine person to be on the ground there, a full-time pediatrician, eventually a full-time OBGYN. I worked there straight out of residency. And then also they had a full-time pharmacist, cardiologist, hem-onc that were basically the anchor faculty for all the departments that wanted to become involved. And they had a rule also, lead with care, and they had a rule that there had to be faculty on the ground if residents or students wanted to rotate, which I felt was very responsible because students actually take resource, they take time, they take energy on already taxed medical systems. But what you see is out of that collaboration also grew grantsmanship in research and training. And you can see this exponential growth shown here on this graph between 1998 and 2017 in millions of dollars. The exponential growth in grantsmanship by having this interdisciplinary collaboration across institution. Most of their funding was NIH, 72%, but some of it, a good chunk, was from foundation or not-for-profits, churches, and private funding, and then some intergovernmental funding. You can also see that publications grew year over year, also in a more linear fashion. The Global Program for Anesthesia and Surgery at UCSF began as a program just with anesthesia and then grew to include surgery and eventually OBGYN medicine and pediatrics. They're focused primarily in Uganda. And their funding has also grown exponentially over time as more and more interdisciplinary collaboration happens. So I think I've made the case of why we should engage. Firstly, there's my moral imperative. I believe that it falls in line with the mission and the vision of most medical schools, which is to train the next generation of socially responsible and compassionate and world-ready physicians. I also do believe, as coming from a sort of mid-tier medical institution, that when you engage in a global health program, you can improve the status and prestige of that institution, you can increase research dollars, and you can attract and retain top talent. So this is the pitch that I took to the executive VP and the dean at Stony Brook, and I said, let's dream big and consider if we had a school-wide global health initiative that focused on care, education, and research, the tripartite mission of this institution. And we engaged across multiple departments. So the first step was to convince the leaders. Here I have a picture of our executive vice president on the right, and our dean at the time in the middle, and our EVP for clinical services, who basically the idea was to develop a shared vision of what we wanted to do, and for them to drink the tea that essentially, this will help their institution to grow, to flourish, to rank, to match, to do more research, to gain more funding. And so after that first phase was essentially to hire a field director to lead it, which is myself, and then to find a relevant partner institution. And so we really wanted to move the institution away from doing individual passion projects where they're based on a personal connection. My family's from India, so I do research in India, and X's family is from Ghana, so they have a program in Ghana. We really wanted to move from having individual departmental-based individual projects to having a school-wide project with one focus institution. And so when I first started, I looked around Stony Brook and I said, well, where are we currently operating? And we looked at the different programs where Stony Brook Medicine was engaged. We looked at Madagascar and in the Turkana Basin in Kenya and Ecuador, Tanzania, China, Philippines. And really, none of these places were partnered with another academic medical center or institution that could have national impact. Dr. Wertheim and Dr. Kanchanski, they had some preliminary visits to Mozambique, as had I, and there is a medical school there. And so what we realized is that Mozambique would form an ideal partner because it's the largest quaternary care hospital in Mozambique, the biggest public hospital that's linked to the Ministry of Health. And this hospital where we work trains the majority of residents in the nation in most of the medical specialties in the country. And Mozambique is an ex-communist nation that still has a very robust public health system and very centralized management. And so it's really basically you train in Maputo and then you get allocated, when you finish your residency, you get allocated to a provincial or a district hospital where you then have to serve out your career. Basically, you just get told, like, you're going to this province, and you either, if you're going to work in the public sector, you go, or you basically resign from working in the public sector. The majority of doctors in Mozambique still work in the public sector. Because Mozambique was on the opposite side of the Cold War, there was not a lot of U.S. engagement. And shortly after independence in 1976, they then fell into the depths of a 14-year civil war, which was very brutal. And so even into the 90s, there was not at all very much American engagement in academia at any of the medical schools. And so there was a strong desire when we went to do our needs assessment in 2019 for Western collaboration. And they helped us to define what the activities are. And I think this is a big lesson in global health, is really listening to what the needs are and focusing on those first. So a little bit about the hospital in which we partner with. We work at Hospital Central de Maputo, which is the largest teaching and referral hospital in the nation. We do about 10,000 deliveries per year. and we see about 100,000 visits in our emergency room. As I said, we are one of the only residencies in surgery and anesthesia. We're one of 5 residencies in OBGYN, but every OBGYN resident has to spend at least a year here, even if they're from a different residency. And so we knew that if we were able to train people with high quality training at this hospital, that we would be able to indirectly have a national impact on the quality of care. So after kind of defining our partnership and who we were going to work with, getting a field director, getting the EVP on board, we then set to create a Center for Global Health Equity, a virtual center where we can collaborate across department and also have a digital presence for external eyes and a place where people can hear about what we're doing and also donate. And this was really how we got our seed money for the program to get the program up and running. And we still continue to run on basically intramural funds plus private donations and a few small grants, which have since been canceled by our current administration. So our third steps were to define which departments to begin with. And since I'm an OBGYN, we began in the OBGYN department with a plan always to engage emergency medicine and surgery in the first phase. And then in the second phase, to engage anesthesia, pharmacy, and nursing divisions. And then after that, move to biomedical engineering, computer science, the business school, and environmental sciences. And our idea was we wanted to create a safe surgery ecosystem because so much of aid is disease focused on AIDS, TB, malaria, Ebola, and so little of aid is focused on actually surgical diseases. And so what we wanted to do was focus on creating a program where you have safety from the door to the floor. So essentially from the moment you hit the emergency room and you're triaged and then you need to go to the OR for whatever reason, or you go to labor and delivery, then in the OR, are you having a safe surgery? Do you have the adequately skilled anesthesiologists, equipment, supplies, consumables, blood? And then from the OR to recovery, do you have well-trained OR nurses, recovery nurses, and then to the ward? And so really, the reason we decided to engage with emergency medicine, anesthesia, surgery, and surgical subspecialties, as well as OBGYN, was really to have this focus in an area of global health that has been relatively neglected. And in terms of Africa, as the continent gets paved through the Chinese bridge and roads projects that are very much alive and healthy across Africa. As the continent gets paved, we see more and more rise in death from trauma and surgical diseases, as well as the existing surgical needs for cancer and obstetrics and gynecology. So that's a little bit about our philosophy. And so the question is, so where are we now? We've been at this now for 4 years. I still feel like we're in the seedling phase of our program. Our first steps were really to build relationships with the chair. This is me sitting with the chair of our department when we started. And then the second picture is that we had a turnover of chairs. So this is me with the chair taking him to the Empire State Building, really trying to build a solid foundation with the leaders of the departments here. Here I'm standing with the residency director and the chair of the academic department of OBGYN, who's my partner in crime and chief conspirator in all that we do. And so a little bit about our labor ward, just so you can kind of travel with me to Mozambique. You can see here in the top box 3 labor nurses, and labor nurses are labor nurses whether you work in the United States or you work in Africa. They all love to sit at the nursing station and gossip, and you have to always pull them away into the labor ward. And I've noticed that doesn't change no matter what continent you work at. Bottom left is our latent labor room, where we have 9 beds of women who are in the first phase of labor, and then they get moved to a private room, which is on the right. And what you can see in the private room is that there's a conspicuous absence of technology. It's clean, it's well lit, but you don't see key things. You don't see fetal monitoring, you don't see a blood pressure cuff, there's no oxygen running. So for dealing with an emergency, it's quite difficult. This is our emergency room for the GYN. Again, you can see clean yet a conspicuous lack of technology. This is our ORs that were recently renovated. And for the surgeons in the group, this is our C-section kit, very bare bones, but clean and welcoming. And so I'm just going to take you through a little bit of our work across these 3 domains of care, education, and research, and how they overlap and what we've been able to accomplish over the course of the past 4 years. So as I've said and kind of pounded into your brains, we lead with improving the quality of care. And my teacher and mentor from medical school was Paul Feimer, and he coined the 5 S's of stuff, staff, skills, space, and systems. And the 5 S's are the ingredients that you need to build a successful global health program. We're blessed, I think you can see from the pictures, to have already adequate and clean and welcoming space. So that allows us to focus on stuff and building skills and building systems. So in terms of building skills, we do a lot of bedside teaching on the labor ward in terms of evidence-based management of labor. And it's really boots on the ground, each one teach one level, where we're teaching case by case, shoulder to shoulder on how to do things. I spend always 1 day in the GYN emergency room per week teaching safe abortion care, and 1 day a week on the labor ward. And I do believe that spending time on the ground allows you to then see where are the shortcomings, where are the issues, what are the needs in terms of equipment and supplies, so that you can tailor and layer upon this foundation short-term faculty visits and donations that help us achieve better care. I do teach in the OR. This is a picture of teaching mini laparotomy for ectopic. When we first arrived, people were getting a big zipper incision for ectopic pregnancy. And so we've transitioned to mini laparotomies in a short period of time. We teach vaginal surgeries. And over the course of 4 years, we've trained 2 specialists to competency on most urogynecologic procedures. So vaginal hysterectomies and colpocliesis and sling procedures over the course of 4 years with visiting faculty. What we do is basically, because I'm here full time, we can then design short-term surgical campaigns where we do the pre-op and the post-op, and we invite subspecialist surgeons to come do 3 weeks of intensive surgical teaching. And through this manner, over the course of 4 years, as I've said, we've trained 2 people up to the skill of fully fellowship-trained urogynecologists, including fistula care. And we've also essentially run teaching in laparoscopy simulations while we have visiting faculty. We have visiting laborists that come and MFMs that focused on team-based care, evidence-based management in labor, operative delivery, and we harness the interest of well-meaning specialists who don't want a career in global health, but maybe want to spend 3 weeks a year or 4 weeks a year helping out. And we can do that because we have an anchor faculty who's able to plan and make the visits worthwhile and useful. We have visiting minimally invasive surgeons that come, where we layer learners upon. So we usually have scrub nurses that are learning to scrub laparoscopy. We have residents who are learning, and we have faculty who are learning. And this is a picture of our layers of learners. On the front row We have scrub nurses and instrument techs. In the second row, we have residents and specialists. And in the third row, we have circulators and anesthesiologists. And so that's a little bit about, the skills building that we do, really doing shoulder to shoulder training. I think one of the major shortcomings of a public health approach for surgical disease is that you can't really teach surgery in a classroom. You have to teach it, and same way, you can't really teach safe delivery in the classroom. You have to teach it shoulder to shoulder, and there's just no way around that. So we really have focused our donations on stuff that will help us to teach and help us to build skills. And so we've donated the initial laparoscopic equipment for to be able to do, with really the motive of being able to do ectopic pregnancies laparoscopically instead of having a big laparotomy. Over the course of the years, we've donated surgical equipment to be able to do urogynecologic procedures. We've donated electronic fetal monitors, portable ultrasounds. We depend a lot on the Butterfly, which is pictured down in the bottom, which is just a handheld ultrasound that connects to any smartphone. We have donated safe abortion equipment. And through private donors who feel compelled to give to our program, we managed to raise enough money to get blood pressure cuffs for our labor ward. We used to have a 26-bed labor ward with one blood pressure cuff, and I'm very proud to say that now we have every labor room has its own blood pressure cuff, and we're able to do point of care hemoglobin testing. In working with the hospital in Stony Brook, we've piloted a novel OR recycling program where we take, the US produces a lot of waste. We're the number one waste producer on the planet. And a lot of that, at least 10% of that waste that we produce is medical waste. And so what we've been able to do is partner with the OR and take either unused equipment that has been open on the field and not used, or gently used equipment that can be wiped down with germicidal wipes. And we put them in recycling bins. And then when people come over, we bring them over here and we re-sterilize and use. So a lot of things in the US have moved to single use that aren't actually single use. And we've been able to essentially build our laparoscopic program, build our safe abortion program through recycling equipment that would otherwise be known as trash to the US. And, a lot of people raise an eyebrow. Is that really ethical? Is it really equitable? I actually feel that it's better for our planet. And we've gotten we've been following our surgical cases, and now we have a cohort of people who've been operated on laparoscopically using only recycled equipment. And believe it or not, over the course of our 4 years, we've actually never had a readmission for severe infection, peritonitis, or even a superficial cellulitis using recycled equipment. In terms of other donations, we've partnered with private donors to get defibrillators or good aspirating machines. So again, I'm shamelessly saying even $20 helps us. I've spoken now about skills and stuff. Let me just talk a little bit about the systems. We've worked to create clinical protocols that work for our setting, but that are evidence-based. We set up a committee, a protocol committee, which is comprised of one member of each division in our OBGYN department here in Mozambique. And we basically look at the state of the evidence. We look at the guidelines from ACOG, from the British College, from the Royal College, and we design evidence-based treatment protocols for diseases that are high prevalence and high mortality. So far, we've implemented 21 standardized protocols. And over the course of the years, what we do is we engage the residents here to write the drafts. They're engaged in the protocol development process. And then we buy equipment that is needed to support those protocols. So for example, we have a postpartum hemorrhage protocol. And so based on evidence that we generated in Kenya, we designed these single-use hemorrhage boxes that have everything that you need to deal with a postpartum hemorrhage. They remain sealed with a zip tie so that when you have a hemorrhage, you have just to go grab the box, open the box, and you have everything you need. And this low-cost intervention, I mean, the equipment here is from the hospital. The only thing that we bought as Stony Brook was the actual red box. But changing the system and changing the protocol has meant that we have reduced maternal mortality from hemorrhage by 30% in 4 years. And so this is how knowing what's missing, having the knowledge of how to create a system that works for patients and work shoulder to shoulder with people, we've been able to actually have significant reduction in maternal mortality. We've also looked to use available resources. So we don't have enough nurses. We don't have enough doctors. And so we've trained the administrators who check people into the emergency room to do initial triage and decide, is this person pregnant or not? We don't know. Let's get a pregnancy test, decide what their level of pain is, their amount of bleeding, and then they put them into a triage group of how we're going to see them. And what we've seen is by task shifting and training the administrative clerks, we've been able to reduce the wait times in our emergency room. We have a lot of community of quality improvement projects, and this is where one of the areas that overlap. We send, or we were sending, I'll use the past tense, we were sending Mozambican residents to Stony Brook using a grant from the State Department. And each resident had an 8-week rotation in Stony Brook where they were credentialed as a resident and could function as a resident. And in return, when these residents returned from their 8-week rotation, they are required to implement a protocol and a quality improvement project. And so based on these exchanges, we've been able to change how we do sign out. We now do a multidisciplinary team sign out based on one of the residents' projects. We have implemented the old-fashioned labor board. Those of us who have gray hair might remember before electronic medical records, every labor ward had a labor board. So we've implemented a labor board. Another resident implemented trauma levels for our cesarean sections so that we can better communicate with the OR how quickly we need to go, how quickly we need to cut. And so you can see how leading with care helps to inform our educational initiatives and our quality improvement initiatives. Switching gears to now our focus on our tripartite mission, our focus on education. One of the great things that came out of the COVID pandemic was Zoom. Here we are Zooming this session today. And so what we've been able to do is leverage the resident teaching that happens at Stony Brook. We ask that the grand rounds and the ultrasound conferences and the resident lectures get broadcast on Zoom so that the residents here can tune in and have didactic teaching. The residency program here until 2021 was really an apprenticeship style program where residents rotate through the different firms, but without supervision, without specialist supervision. So and without didactics, without competency-based curriculum. And so we had a lot of gaps to fill. We made a didactic curriculum for the residents here using experts at Stony Brook who may not want to travel, but are engaged and want to help. And so, we have our MFMs pictured here, our ultrasound experts who give conferences, and we use AI to have real-time subtitles, closed captioning in Portuguese. And so we've managed to engage the entire department practically to come give lectures virtually to our residents here in Mozambique. We also are leveraging mobile technologies. We have a subscription for an app called My Tip Report that allows specialists to rate the competencies of their residents in real time on their smartphone. And so we've developed this digital platform for specialists to be able to evaluate the residents. We've developed a case register so that residents can keep track of their cases and case minimums that they need to achieve before graduating. Essentially, before it was like rotate for 6 years, take an exam, and then become an OBGYN. We've tried to introduce the concept of evidence-based medicine by introducing Journal Club once a month, and the residents have to be the one to present that journal article to the group. We've implemented a boot camp where incoming interns get a 3-day course, crash course on everything from how to use PubMed to how to resuscitate a newborn, how to wash your hands properly in the OR. And this has been adopted now hospital-wide. They're adopting an intern boot camp. We have this simulation truck that was donated by the Royal College of Surgeons and Cooksexa in the 90s, which had essentially been defunct and abandoned. And we've essentially turned it into our simulation space where we do both wet and dry simulations. We run a simulation about once every 4 to 6 weeks. We call the curriculum Simulations to Save Lives. And the idea is that when we have visiting faculty, we engage them in running the simulations. We do postpartum hemorrhage sims, breech sims, shoulder dystocia, 4th-degree laceration repair, and on and on. So here are just some examples of the sims that we run in our simulation truck over the course of the year. The first cycle of our 2-year sim curriculum I ran in collaboration with Mozambicans. Our second cycle, again, we ran in collaboration, but now we're entering our third cycle of sims. And now essentially I'm just the logistician, and the Mozambicans run the sims and I assist with logistics. So we've really tried to create a transfer of ownership in terms of who's running the sims. And here are just 2 colleagues actually making the low-cost simulation models that we use. This is a class where we're doing ACLS simulations, ultrasound simulation. And we really focus on having bilateral exchanges. So this is a picture of Dooney, the female resident who is from Stony Brook, who rotated to Stony Brook, and Santos, who's a Mozambican resident who rotated to Dooney, who rotated to Mozambique, and Santos, who rotated to Stony Brook. So we try to have 1-to-1, if not greater number of Africans coming north as Americans coming south. We've been able to develop a Global Women's Health Fellowship, although we have yet to rank and match our first fellow. And so I've spoken now a lot about care and education. I'll briefly touch on research in the last few minutes. Essentially, this is a free course that's run by the NIH, and we require all of our residents to take this introduction to the principles and practice in clinical research. And over the course of a few years, we've actually researched our residents here and done some evaluation of our curriculum standardization and low-cost simulation program. And we were able to present this in FIGO in 2023. The overall rating of our didactic program is either excellent or very good. Our SIM program is rated as excellent or very good. These are the ratings that residents gave to each of the simulations. And we've been able to publish this in the Journal of Surgical Education. We've also done some research on access to medication abortion in the community here, and I'm going to skip over those findings just in the interest of time, and just briefly talk about some of the other ongoing research. We have some research going on how we could perhaps implement a modified massive transfusion protocol. We're looking at validating the use of the butterfly as opposed to conventional ultrasound in obstetrics, and novel techniques for preparing the cervix before second trimester pregnancy. So our future directions are including expansion to other departments. This is a picture of all of the emergency medicine doctors across the nation in Mozambique. And you can see it's less than a dozen people. So we are committed to supporting the emergency medicine department with the development and supporting the junior residents. We have expanded our resident exchange program to include emergency medicine, and now we send residents from Mozambique to Stony Brook, and Stony Brook emergency medicines come to Mozambique. We've conducted many point-of-care ultrasound training courses in the emergency department, and we're looking to actually hire an emergency medicine faculty who will be the anchor and core person for emergency medicine. These are two residents who rotated to Stony Brook from Mozambique. In our surgery department, we're currently recruiting a program lead. We had a program lead for 2 years and then she left. And our goals in surgery are, again, to improve care and resident education, teach improved surgical skills, and ultrasound for the surgery residents. We have had some of the surgeons from Mozambique travel to Stony Brook to get vascular surgery training, specifically minimally invasive catheter placement for dialysis and fistula creation. We've had our first surgical nurse come and teach the importance of counting instruments and spudge counts and surgical check and implementing the safe surgery checklist. This visit happened over the course of last year. And this year, I'm super excited that we have, for the first time, faculty anesthesia who will be coming for 3 months out of every academic year. So I hope over the course of this hour, I've been able to explain our philosophy, talk to you about the core ingredients for a successful global health program that leads with improving the quality of care, follows closely with improving the quality of education, and then layers upon that collaborative and relevant research to the population that we serve. All of this is done based on individual funding and small grants that we receive from private foundations. And I want to give a special thanks to my son, who's been walking around the room listening, and if you can see on the video, is standing right next to me, because he's the consummate host of every single visiting faculty that we have. So he's my VIP on the team. And so with that, I'm going to close and thank you all for listening over the course of this hour.
Thank you so much, Dr. Washington. Absolutely spectacular. Just so phenomenal. I know we're at the top of the hour and people might have to leave to other engagements, but if you have time, perhaps you can entertain a few questions. Truly blown away yet again, but just want to allow the opportunity for anyone who might have burning questions to ask you. I mean, while we're waiting for people to either drop it in the chat or just speak up really quick, something that I wanted maybe you could just talk about just practically. You know, it's so innovative, and the fact that you're on the ground, perhaps could you tell the audience, like, how many months out of the year do you spend in country? What does that look like? And
Yeah,
just look, do you speak fluent Portuguese? Like,
yeah.
just love to hear practically how you navigate that for you and your family.
Yeah, so I have tried to flip the paradigm. A lot of people who do global health spend, 9 months a year in the US and do, several short trips a year to their partner country. So I have basically flipped that, where we live here in Mozambique and I spend 10 months of the year here. And then I spend my son's summer vacations in the States, working like a dog, doing a ton of labor and delivery to make my salary. And so about 2/3 of my salary comes from the 10 weeks that I do on labor ward over the summer. And then the rest is grant funded. And so essentially, I just talked to the EVP and the dean human to human. Like, if we're going to do this, we need to put boots on the ground so that you can be responsible, have your students come, have your residents come, have your faculty come, and be able to move the needle in terms of improving maternal mortality. And what that practically means is that I have to have a home base here to run the program, to be able to pull faculty who may only want to come for a few weeks or are uncertain and have never done global health but are super smart and interested. And so having me here allows the other people to engage in the sort of conventional paradigm.
Thank you.
Just to piggyback off of that. So because I'm like, okay, hold up. How do I do it? Okay. Sorry, Krista. Bye. Um, just that was that over time? Did you arrive to that conclusion? I understand that if everybody's shifting, then you don't have really a sustained presence. But was there a point, or is there a point where there's faculty or people who are in Mozambique on ground, like in the local medical education community, who are the constant force as well? Or was it a gradual thing over time, or did you start out at the beginning of like, no, this is my commitment?
No, I started out at the beginning. Now this is my commitment. But I didn't come out of the womb with that idea. So I have been hewn by years of working in other global health programs, and I've seen what works and what really doesn't work. And I can tell you what really doesn't work is a surgical campaign. What really doesn't work is people flying in like Operation Smile and operating on a bunch of cleft lips and palates, or I'm coming to do eye surgery for 3 weeks and then leave, because you don't leave anybody trained. You feel good. You did a bunch of surgeries. You feel good, but you don't leave anybody trained, and you don't leave a system, a space, staff, and skills for them to carry that forward. So I knew off the bat that like short term, or I just saw over the years that short term doesn't work. So knowing what short term doesn't work, and then working in the IU Kenya program and seeing that their philosophy was like, no, we need a program lead, boots on the ground in each department, upon which you can layer the people who want to come do a surgical camp, who want to do a little research, who want to, send a resident because they're a residency director. But when you're the person on the ground, you're the person coordinating all these short-term things so that it weaves together to make a net of relevant and useful interventions that are relevant and needed. And so I think, that it also allows you then to have the consistency to build responsible and collaborative research, where you're actually asking a question that's relevant to the people that you're working with and answering that question in a relevant way. I don't think I would have ever thought of like piloting a different massive transfusion protocol than what we use in the States had I not come and spent time and know like blood. We don't have blood. We can never have a massive transfusion program here the same way we have in the States. So what can we do? So I think over years of seeing what doesn't work is understanding what does. And then you need to have to make something like this happen, you need to convince the C-suite that it's worth their time. And so that's where the first half of my talk comes in, is that the data is there supporting this, that this is what results in more NIH grants. This is what results in better funding. This is what results in ranking and matching better trainees, and retaining top faculty, because they think in terms of dollars and cents and how's it going to benefit their institution. And so that's why I spent the first whole half of the talk of like, how did this come to be? Because you need to get the C-suite on board.
So powerful. Thank you. Other questions?
Yes, Dr. Sierra, I wanted to ask you, definitely you have amazing institutional support, and I love the idea that the whole university took this as a whole university kind of focus, right? It's not, so there's a lot of different faculty looking at Mozambique and this partnership. I wonder how you make happen the bilateral exchange, because we find so many hurdles that come, there are institutional hurdles, departmental, institutional, there are visa hurdles, even to, bring someone for a short
Yeah.
period of time. Tell us a little bit about that area, because we are trying to work on that at UMass right now.
Yeah. Let me talk about that in layers. So first, the funding. Our funding disappeared with the complete pullout of the State Department. We had State Department funding. We had a U.S. Embassy grant from actually the Public Affairs section of the U.S. Embassy, essentially funded our exchange program essentially as a way to promote American culture. And I wrote a grant saying, like, the culture of medicine is different in the States, and it's very different. We believe in patient-centered care, the best of American medicine, not the worst, but the best of American medicine believes in patient-centered care and shared decision-making and discussing the treatment plan with the patient and informed consent. And across Africa, that is not how medicine is practiced. The majority of medicine is just given to the patient, here, take this. No one's ever explaining, what is it for? Why, or the surgery you need is this. You're not explaining why or what the alternatives are. So basically, the initial grant was, how do we export the culture of American medicine? To do that, you have to have an experience. You have to see what it is. You have to know what American medicine is. You can't really imagine something if you've never seen it. So we were able to convince the State Department to fund these exchanges as a way to export American medical culture. And so that's where the funding came from. And I do believe it's replicable if we eventually have a State Department that is functioning again. So I think that was how we initially funded it. But each resident costs about $10,000 for their 8-week rotation. And so it's another price point that we go to private donors and we say, listen, $10,000, it gives us one resident experience. And we have that price point kind of costed out and budgeted out. We know what we're asking for. So that's the funding. Then there's the regulation. So the visa, because our funding came from the State Department, we were able to talk to the consul and be like, for us to execute this exchange, this learning exchange, we have to get visas, right? So as part of the exchange, we were able to facilitate the visas. And then the regulations vary state by state in the United States. And so we're a state institution. We're self-insured. We don't, our med mal is self-insured. I'm assuming UMass is also a state institution and is self-insured. So that's already one major hurdle done, because basically your legal counsel can decide that they are or aren't going to insure the visiting residents. And then the state law in New York is different than the state law in Mozambique. And in New York, no residents have a medical license, whether American or not. Not a single resident has a license to prescribe. They're all prescribing under attendings. And so whether that resident comes from Mozambique or comes from New York, they're all prescribing under the supervision of a faculty. And so I don't know the law in in Massachusetts. I don't know if residents have their own medical licenses or they're practicing under an attending license. But I do know, for example, in California, where I trained, I got my license after internship year, and I was prescribing under my own license. And so that was the hurdle that was unsurmountable for Californians, because there's no way a Mozambican can get a California license. But in New York, we don't have that legal framework. I just want to give one case study of Vanderbilt, actually, because they had similar problems in Tennessee, where the residents had their own license. They actually lobbied the state to change the law so that they could have resident exchanges. So there's that policy level where they had to lobby the state to change the law to be able to enable that. So I happen to work in a state where I don't have a law that's prohibiting a foreign resident from acting as a resident.
I can tell you that we are working along with other people in Massachusetts to try to get residents coming from abroad special type of license. And yes, they need to have a license residence. Yeah.
Yeah. So, it's a little bit of luck and a lot of persistence is what I would say.
Other questions? I mean, I know, Sarah, I have one which I think is on the minds of literally everybody in the space right now, given this current environment, right? And you've touched upon it so eloquently, and I really so appreciate that. In this current environment, obviously, with where the US has withdrawn from WHO, USAID funding withdrawn, everything, you know, has really put a lot of this important work in peril. What can we do, whether as institutions or as individuals committed to this work on our global citizenry, to, hold the line or mobilize the kind of intentionality around the importance of this work beyond, as you have so done, individual donations and seeking to obviously continue the uh, persuasion of philanthropy, obviously, but
Yeah.
like, what other things can we do? What about institutional collaborations? Just
Yeah.
trying to brainstorm because obviously that's the
Yeah. I
elephant
think
in the
it's
room right now.
Yeah, I think we're in a really, really difficult time. I mean, I wish I had the answer, Krista. Seeing what's happening to Colombia is devastating. Seeing what's happening to academic freedom is devastating. And I'm daily thankful that most of my funding does not come from USAID and does not come from the State Department. I'm daily thankful that most of my funding actually right now comes from Canada. And private donors. And I'm thankful that our EVP sees meaning and value in this work because we're all in that same soup of seeing all the funding being evaporated before our eyes and not just like pulling out. And so I think speaking truth to power is what all of us can do. Continuing to care about diversity and equity and inclusion and globalism and the health of the bottom rung is our right. It's our right to speak about that and care about that and work on that. And I think that continuing to be vocal about it, and I actually feel like the universities ought to band together and stand up and write. The chancellors of every Ivy need to come together, write a letter, have a meeting with Congress to say this is anti-constitutional what's happening and jeopardizes what makes America. Because what makes America is the innovation, is the research, is the diversity. I mean, the reason why we are head and shoulders ahead in terms of technology and health outcomes is because of academia and because of our huge, giant NIH budget. I gave a talk as a chief resident now almost 2 decades ago about how the NIH budget is exponentially larger than Canada, Europe, Japan combined. And without that, the innovation, we won't have the money there to do it. So I don't have the answer, Krista, but I do think continuing to speak out, continuing to use the words that we want to use, and partnering and convincing our leaders to partner and speak up to Congress and the executive branch. I feel very disappointed in our Congress at the moment. And I feel, I'm hoping that the judicial will do their job as they are trying to do. But I don't feel like I have the answer. I think We have to resist. We have to resist fascism, and we have to resist dictatorship. I'm living in a dictatorship here in Mozambique, and it ain't pretty. um, and so I think as academics, who all of us here are part of the quote DEI community, we have to stand up and resist. We have to speak out. I mean, I know I've personally already written all of my members of Congress to impeach. And if you haven't yet, do so. Write your member of Congress, write your senator. Like, if you have an online platform, like tweet it, Instagram it. We have the only thing we have, I feel like, is our voices, our power. And tell your EVP, tell your deans that they have to stand up and combine, collaborate, and speak unified truth to power. I've never been somebody who is shy to say what's true, but I know that there's a lot of fear right now in the States of like, I'm going to lose mine. But we can't just roll over.
So powerful and poignant. Thank you so much, Sarah, for speaking such truth to power and really inspiring all of us. Your work is so phenomenal. And I wish you continued success and, look forward to opportunities, for us to partner in some way, to build upon your work and to replicate it in other, countries. It's truly a game changer and an exemplar. So thank you for sharing your wisdom with us today.
Thank you for
And thank you.
having me.
Yeah.
And maybe we'll do another thing in the summer when I'm in the same time zone and you can have broader participation.
But we'll definitely share the video because I know there are many who are, in clinical environments that couldn't participate, but they'll absolutely view the recording. So this has been so
Great.
impactful and powerful, and I can't thank you enough for your
Thank you
time.
for this group, and yeah, keep fighting.
For sure. Absolutely.
All right.
All
Be well.
right. Be well, everyone.
Thank
Thank
you.
you. Have a good rest of the day. And thank
Bye.
you again, Sarah. Bye-bye.